All right, welcome to the scan along video for the hip region. Before I really get started, just want to describe a couple things. I'm going to be using a linear probe today, but that's because the machine I have has capabilities to kind of do a deeper, to image deep with it. But you can use a curvilinear probe, and I recommend that for deeper structures in the hip, and that can help you get a better image and image anything deep. Is in the hip region, that's where it's definitely more valuable to use a curvilinear probe with a lower frequency probe. Mine is a 412, so it has the capabilities of imaging deep enough for the sake of today. The other thing is the patient setup is, for when we start doing, we're going to do anterior and medial here, and then we'll do lateral and posterior. Before you get started, you can see draping, making sure your patient is draped appropriately and knows where you're going to be scanning is important. I like to set up my patients and have my imaging device towards the patient's feet so they can actually see the image and I can explain things to them, but then I'm also not kind of looking over top of the areas that I'm scanning. And then when I handle the probe, especially anterior, I'm going to probably handle the probe so I'm only just in contact with the lateral portion of it, and the part that's going closer to the midline I'm not handling that part of the probe. So when we start and do the anterior hip region, the first thing we're going to look at is the femoral acetabular joint. And to do that, you can't put the probe down and try to look for the femur, but as you get closer to the hip, we're going to turn the probe a little cephalad, and we're going to look for the femoral head here. And so here's the femoral head, and we'll turn the probe a little bit so we can get some of the femoral neck. And how much you have to tilt the probe is really going to depend on your patient. There's a little bit of variability in those angles from one person to the other, and then also making sure you know how much rotation is their hip in. Are they letting their foot fall out in external rotation or the internal rotation? All that can determine how you have to position your probe. So from here, we're going to identify the femoral head, and right on top of it is the joint capsule. Then we're going to move till we can see the acetabulum and a little bit of the labrum here, right, this joint. Now, the labrum's deep. We can see part of the labrum, but we're not really going to be able to rule out labral tear. But you can scan a lot of this hip region, kind of proximal and distal. We're going to look for fluid in this joint, in this recess right here where this joint capsule, and we're looking to see, is the capsule thickened and large, and then here at the neck, is there fluid that's accumulating right here? This is where it does accumulate, right here, not deep in the joint, but actually right here, because this capsule goes all the way over the femoral neck region. So we're going to look for all those structures. Then the other thing we can look for is different connective tissue, and namely the psoas tendon I like to look for. And here it's actually right here, right above the acetabulum here, and we're looking for, this is where you could have any kind of bursal fluid. Sometimes you might find it a little closer to the femoral head, but here we can see it's right here is the tendon here for the psoas, the iliopsoas. And we can take a look at that in long axis as well. So if we turn our probe kind of in long axis, then we can kind of see the psoas kind of going right over top of the femoral head and acetabulum here. And that's just, we're looking for any kind of fluid accumulating in the bursa, as well as identifying anything there. After we've looked at that, I like to look at structures, muscular structures above the hip region, namely we're going to go to the AIIS and the ASIS. Now the A, if we move right up from the femoral head, proximally, this first bony acoustic landmark is the AIIS, which is where we're going to find the rectus attachment of the rectus femoris. But we're going to keep going up, up, up until we find the AIIS, and coming around the ASIS, that is going to be very superficial, is what we'll see is the lateral, the TFL, and medial, the sartorius. And between those up here, usually you can see the lateral femoral lateral femoral cutaneous nerve. Usually is between those two muscles, right on the top. It's this cutaneous nerve, very superficial. And so if you're looking for that, you can palpate that if it reproduces structures. And we can follow these two muscles distally as well. But as we come down, when we find this AIIS, this is where the rectus femoris is going to come off and turn into muscle there. And we're going to look at that in long and short axis. And we go to long axis. Here it kind of comes in at this unusual angle kind of between all the other different muscular structures, which can make it difficult to identify. But right here is the AIIS, and you might have to turn your probe just a little bit, and so you can see it attach all the way down here to the bone. And so if you're looking for any kind of tears, enthesiophytes, anything like that, and here's where you're going to identify that. And you can see it's right over top of the femoral head and acetabulum, and there is actually some of the fibers that do blend in with the joint capsule a bit, so you might be able to identify those too. Okay, after we've looked at those structures, we're going to then look at the medial portion of the hip. And so for that, we're going to have the patient kind of bend their knee up and then just kind of let it fall out. Kind of, we call this a frog leg position. And really what we're looking for here is the adductors. And so the adductor, we're going to take our probe and position it right on top. And here's where I think the probe handling is really important. And the draping is really important. But if you can move your probe in, we're going to look for the adductors, the adductor longus, brevis, and magnus. You can see they kind of have appearance here, here, and deep. And as you move closer to the pubis bone, you can actually see them all kind of come in on the proximal attachment here, the common, and they attach down like that. You can also look at it in short axis here, where you're identifying 1, 2, and 3. And here we're looking for any kind of large adductor tears, or even enlargement of some of the common adductor tendon as well, which can be seen in a tendinopathy. After we look at the anterior and medial thigh, we're going to look at the lateral thigh. So we're just going to have our patient in side lying, and here we're going to palpate the greater trochanter. Now keep in mind, you have to pay attention to when people lay side lying, how much internal rotation does their hip go into, because that can make it a little bit difficult. But we're going to identify the greater trochanter. We're going to put our probe right onto that bone. And what we're looking for, is what I mean by they're in a little bit of internal rotation. We're going to look for the anterior and posterior facets of the trochanter. And the way you find those is the posterior has this nice round, this is posterior to the right, and anterior is to the left. And so the anterior facet is going to have this nice little, almost like a little hill, a little mountaintop part of this bone, and it flattens out here. And the posterior has this rounded appearance here. And so the posterior is going to be the attachment for the gluteus medius, and anterior is where the gluteus minimus right here is going to attach. And so always remember, glute min is going to be anterior and deep, and glute med is going to be posterior and more superficial. Why that's important now, obviously the glute max is going to be a large muscle on top of everything, but as we find right here this anterior facet, we can look for the glute minimus here in short axis, which is this smaller structure here attaching right here, and on top, more superior or more superficial, is the glute med, which is going to come down and attach more to on the back end to this posterior facet here. So again, easy way to do that is find your greater trochanter, locate the anterior facet and posterior facet, and here's glute med attaching, and here's glute min attaching right here. And so then you can look at those in both short, and right here's medius, right here's the glute medius attachment right here. And you might move your probe a little bit to identify that right here as attaching glute minimus, and then medius, usually a little easier to identify as that comes down. Now, you're also looking for any kind of like bursal distensions here, any tearing of those fibers here, or any kind of enlargement of the tendinous structures as they come down. Okay. The other thing you might find here is the IT band, which can be a very large connective tissue here on the lateral thigh as well. And the IT band you can actually image from the thigh all the way to the lateral femoral condyle. Even down here even. I'm sorry. So this is the IT band at Gertie's tubercle in the tibia here, and so you can actually follow this over the lateral femoral condyle here, and if you wanted to, we could follow it all the way up the thigh here, where it's coming right over top here of the trochanter. So if you want, you can do that from distal or proximal, or you can try to find this IT band here and see if there's any fluid right over top of that connective tissue structure, distal or proximal. Okay, after we've done the lateral hip, we're going to do the posterior hip. And so hamstrings are very good muscle to use ultrasound to image. A lot of the tears occur, mid-belly or proximal. So making sure you can scan the hamstrings, the entire length of them, and making sure you can identify them is extremely important. So as soon as you put your probe down, we're going to have to adjust our depth. I like to identify first the semitendinosus, and then from the semitendinosus I'll find the membranosus, and the biceps femoris. So approximately about like at least a third up the thigh, we're going to be medial, because that's where the semitendinosus is, and we're going to slide our probe up and down. And what we're looking for is this thing called the veil sign, and this connective tissue right here around this bundle and this hamstring right here. There's only one muscle that has that, and it's the semitendinosus. And so once you know you're at the semitendinosus, then you can look at this muscle, distal, and watch it turn into a tendon, as you recall from the knee region here. And then as you scan this structure, you can scan it all the way distal to where it attaches at the pes anserine. And then you can move to the muscle underneath it, which is the semimembranosus, and follow the semimembranosus up here. And watch the membranosus turn into a tendon more proximal. Okay? And then here's this is the, now we know it's semitendinosus again because of the veil sign. Membranosus was here. There it's turning into connective tissue. And we're going to follow this stuff all the way up as well, and we'll show you how to do that. So here at the veil sign, now we need to look at the biceps femoris, and so we'll move laterally. And here's where we're going to look for what's commonly referred to as the Mercedes-Benz sign. So once you find the veil, and you know you're at the semitendinosus, we're going to move a little lateral. And here's where this is the Mercedes-Benz sign. So you should find a very hyperechoic area right lateral to the tendon. This is tendinosus. So this hyperechoic circle right here, that's actually the sciatic nerve. And the Mercedes-Benz sign is this connective tissue that separates the tendinosus from the biceps femoris. And so it's right here. It connects all the way down to the connective tissue around the sciatic nerve, and then you have a connective tissue here that goes from lateral to medial that separates the hamstring muscles from the adductor magnus, which is this large muscle underneath. Okay, and so that's what the Mercedes-Benz sign is. And so once you identify that, then you know this is the biceps femoris, and you can follow the femoris right here all the way down to the knee as well. And I'm running out of gel as I go distal, so you might need to apply more gel. All right, so that's how to scan each one of the hamstrings, at least at mid-belly. Coming up proximally, again, we're going to find that veil sign of the semitendinosus, and we're going to follow this common connective tissue all the way to attaches to the ischial tuberosity. And so make sure you're here on the lateral portion, and the common hamstring is going to attach right here. Kind of from here all the way around. This is the common. And you can take your probe and move it from short axis to long axis, and look at the hamstring attachment at the ischial tuberosity. And so you're making sure it comes down and attaches. You're looking for any, if it really tears, a massive tear, it might avulse some of the bone here off. And you can even do a few things here at the attachment. You can have them flex their knee a little bit. And so you can see those, make sure it's attached to that bone. Go and do that again. So what you're looking for is any kind of retraction here. Go and relax. And go and bend up a little bit. You don't even need to bend up that much. Yeah. And so you can do that with all the different muscles and watch them just move dynamic in flexion extension. Okay, so this concludes the hip scan along region. Thank you.